these years. The other can the practical features of malnutrition, features they can report guidelines prevention of malnutrition. So both of those scientists, they are working on malnutrition, but on different aspects. How they go into the depth of that research and how they are making the broad question to be answered, that is important. And the conclusion should match with the research question. If someone says that I want to do all the aspects of the malnutrition, whether it is biochemical, whether it is clinical features are involved, whether it is about the growth charts, I want to reinvent each and everything, then it is not research at all, right? It may help in the healthcare delivery, right? But the most important part of research is that the person should be very focused, and that new knowledge may later be translated into any clinical practice. So from a very broad start, we come up to a very focused question, and then we have again a very broad discussion part, and we come with certain conclusions, right? So we have talked about in the introduction that we have to introduce our topic and how to introduce. First, we have to give the statement of the problem. We have to give the burden of the disease or prevalence of the problem. We have to know what others have found by literature review and what are the gaps that have been in the existing literature. Then we have to hook that gap and come up with the rationale or justification. Then we have to come up with our own aims, objectives, as well as goals, right? So this is the everything that I have been narrated. That is the part of introduction. We have talked a lot about literature review, and you are right. What is the difference between literature review and the review of literature? Review of literature is reading, and literature review is basically writing the critique about whatever you have read so far. So research question, then methodology. When at justifications with methods, we called it methodology. Results, and then discussion and conclusions. We have talked about the level of evidence. Again, for the best level of evidence is meta-analysis. And the meta-analysis is, what is meta-analysis? Dr. Hansa, you have to speak in your mic, please.
Meta-analysis is the higher level of evidence in the quality of information. In this, we gather data from different type of articles according to our search question, and then analyze this data according to our search question and find or finding other, and then interpret our results cumulative
Very nice, Dr. Hansa. The statistical analysis about the PRISMA guidelines, and I is now well versed what is PRISMA guidelines and how the inclusion exclusion criteria has been established. And after establishing the all the inclusions, removing the duplicates, and removing all those who are excluded from the study, we combined all those sample sizes and do all the analysis again. That is the meta-analysis. And meta-analysis gives the best level of the evidence, right? So we have decided that the meta-analysis is lesser having bias, lesser confounding effect. Then comes the systematic reviews. We know then comes the randomized controlled trials. However, if there are multi-center randomized controlled trials, they have more level of evidence rather than a single centered randomized controlled trial. We talked about the cohort studies. We know the cohort studies are very difficult to do. One of a very famous example of cohort study is Framingham Heart Study. Very nice. Framingham Heart Study. So the Framingham Heart Study, there are more than 4 generations now that have been included in these studies. And it has given us all those risk factors that we are now looking for the secondary prevention as well as tertiary prevention of cardiovascular diseases, cerebrovascular accidents, MIs, etc. So how we know that smoking, diabetes, hypertension, hypertension, and dyslipidemia are the four risk factors of a high level of evidence through the cohort study. And the cohort study is Framingham cohort study. Framingham is a place near Boston. And this study has been done over a long period of time. And what evidence it has produced? It has a very strong evidence for the practice of cardiovascular diseases and for prevention of all those strokes and vascular events, right? So the cohort study is very difficult to do. We know a lot of cost has been involved in it, and we know that a lot of samples has to be taken in. Population has to be followed up for a very long time in order to get a very good level of evidence. Those cohort studies that are being followed for lesser period of time, or those cohort studies where the samples are being dropped out during the study, their level of evidence would be lower rather than those studies that have been followed for a very long period of time, right? Yes, iteration bias. We have to minimize the iteration bias by decreasing the dropout from the cohort studies. As it is a follow-up study, and most of the cohort studies are prospective studies. And even if we have the retrospective cohort study followed by the prospective study, still the element of loss to follow-up is much more than the case control studies. So the cohort studies, yes, iteration bias has to be controlled. The next is the case control studies. We know that the case control studies gave us the level of evidence, but much lower than the systematic reviews, RCTs, cohort studies. And again, the case control study has given us a very strong evidence about the association of lung cancer with smoking. I have told you about the whole story of Dunhill, and the whole story how they worked, different researchers, they worked together to know what is the association of different carcinogens with cancers, and they come up with certain preventive strategies or plans to implement prevention. So the case control studies, again, they gave us the level of evidence, but their level of evidence is much lower than the cohort studies. What are the different biases that decreases their level of evidence? One of the biases, the recall bias, because the cases and controls both have been asked certain questions and they have certain records. So these records has to be compared. There are the chances of having misinterpretation or the recall bias. There is a chance of even having the lead time bias and Bergsonian bias. Why Bergsonian bias? Because we know the most of the cases they appear in hospital settings, right? So in Bergsonian bias, we know whenever there is a setting, more people would appear into that setting with certain disease. And there is a very famous study where the pancreatic carcinoma was associated with coffee, right? Later on, it was found that this study was done in a hospital where the pancreatic cancer treatment was being offered, and it was one of the famous tertiary care center in that locality. So all those people who have pancreatic cancer, they prefer to report to that area, right? And they took the control group also from the vicinity of that hospitals, right? And they are usually what they have done that these people who were taken as control, they were very close relatives of the people who developed pancreatic cancer. There were different types of bias that has led to the wrong results. The conclusion was totally wrong. Pancreatic cancer was not associated with coffee. But what has been done? First, the pancreatic cancer patients, those who were drinking coffee and their relatives who were or who were second, as it was a tertiary care center and it offered the best treatment. So the most of the pancreatic cancer patients, they reported to that facility. And it was a matter of chance that most of them, they were coffee drinkers. So if we are having the cases from a certain setting and not from the multiple settings, And from the multiple regions and from the multiple countries, usually we got the bias in our study, right? Even you can think if someone really want to establish an association with coffee drinking, what should be done? The cases of pediatric cancer should be taken from different centers, right? From US, from UK, from Pakistan, from Italy, from Africa, from different continents even, where there are different dietary habits, where there are different coffee drinking habits. Even people here in Pakistan, they drink coffee, but they are not as fond of coffee as in US or in certain other countries. So in order to decrease the bias, it is always preferable to have multi-center case control studies rather than a single case control study, right? Next, we have case series and case reports. Again, the case report, when there is very unusual occurrence of any problem or disease, we prefer to have case reports. However, if there is a continuity of the case reports, for example, 2 or 3 cases, then we call it, after 3, we call it case series, right? We have seen in COVID-19, the first case was reported, and Dr. Lee was the scientist or the researcher or the doctor who has reported it from Wuhan, China, right? So that was the case report. Later on, there were many cases that were reported from China, US, Italy, etc. So it becomes a case series. So case reports, they are phenomenal when some pandemic, epidemic, or certain diseases, they are having their way to the global community. And sometimes even the rare diseases, if they are being picked up by certain researchers, it is important to get it published so that the other people know how to manage it and how to give the evidence-based practices to such people. And the last level of evidence is through background information or expert opinion. We know most of the experts, they are very well versed of what is going on in their specialty. How? Because they read different research papers, they are writing certain research papers, and they are being invited as experts at decision making fora as well as in conferences. So they have that important thought process of what is going next and what would be the future plans and what would be the strategies for future. So the expert opinion, yes, it is important, but for the level of evidence, we have seen this, that it has been placed at the lowest level. So what is systematic review? We have divided it in two terms, systematic and review. I will not go into details. What is systematic review? We have discussed this, how to select a topic, search the literature, develop the argument. Then after developing the argument, we again have to go back to the literature and to see what the literature has found. Then we have to critique the literature, that if it is right, why it is right. If it is wrong, why it is wrong. Then we have to write the review. And here, the review of literature becomes the literature review in the sixth step. So how to steps in writing reviews? First, we have to plan. If our planning is good, we can have a very good reviews. Otherwise, even on the first, putting your step on the first stair, how can you reach up to the top? So the planning is the first step in that ladder. Second is the research or reading. Third is analysis, then drafting and revising. We have talked about Prisma guidelines, and today I have seen Dr. Naila. Am I right? Right. Thank you so much. मैंने कहा कोई चौथा तो नहीं है ना जो claim कर रहा है. Right. So identification, number of recall identified through database search. जी डॉक्टर मेहा कितने identify किए थे आपने? 214. From? Okay. You have to tell me how many from the Google Scholar and how many from the PubMed. And what was the topic? Okay. Have you removed the duplicates? कितने duplicates थे? 128 were duplicates. So your number comes to be 86. Vaccination is something that is being given importance all over the world, right? Why the people are hesitant? It is important, but the publication and literature is coming up, and yet it is a burning topic, and still the publications are much lesser in number. Dr. Naila, would you tell me how many records you have found?
And I have found 296 records, 250 from US colony and 46 from permit. And then when duplicates remove, then
Why you both haven't gone for Medline?
मैं खुल ही ना उसको खोलने के लिए क्योंकि सर्च बार ही नहीं आ रहा था.
The second important thing is you have to search in personal protective equipment. That is a much older topic rather than vaccination. PP starts in the last year, right? And everybody knows something about PPEs, personal protective equipment. Not even the healthcare workers, not even the doctors, nurses, and paramedics, even the layman, as I have told you in the morning about biosecurity bubble. What I said, that even the drivers and those who are chauffeurs, they have to wear the hazmat suit. What is hazmat suit? It is PPE, personal protective equipment. So it is protective equipment is something that is not as new as vaccination. A lot of work has been done in the previous year. From March, we are now again in March 2021. In this previous 1 year, thousands of research papers have been published. Even the guidelines have been published, right? Even the Punjab government, I am the part of that guidelines that have been made by the Punjab government. We did all personal protective equipment. What should be the level 1, level 2, level 3, level 4? And there were thousands of articles that were available, right? So whenever you are identifying any topic, you also have to justify it. You have to bring some rationale to it, right? So if you think that your identification is not correct, you can't go to the next steps. As I have told you that there are 4 important steps in systematic reviews. If your identification, it means you are only looking for the published data. And yesterday we were talking about the unpublished data, right? We have talked about the publication bias. Dr. Marin, perhaps you were the one who told us about publication bias, right? So what we have done so far, we have to implement it. Now we have to practice it. Even in this class, I want you to sit here each and every hour allocated to you. You have to make it according to the Prisma guidelines because practice makes a man perfect, the first thing. And without practice, there is no fun in reading. Even I presented it today, I have presented it yesterday. There is no implementation. It means all this effort has gone in vain. It is wasted. So the most important thing is to practice it. And whenever you are practicing it, justify it. That, okay, we have found this record and this was in PubMed, it was in, there is a very famous European website of SQL where there is unpublished data is available. There are many other sites where the thesis and dissertations are available, right? So the unpublished data, you have to separate it from the published data, right? And what I have said in yesterday, just yesterday, I have told you that you have to specify how many records have been found from this particular database, right? So when you are telling me that this is from PubMed, automatically you have to give me the exact number, Medline exact number. And if within seconds, I can know that this identification of the record, it is not proper, right? And even if we go to the unpublished data, I am sure there are thousands of vaccines that were in animal trials and they never come up for clinical trials. Their data has been uploaded somewhere. So giving a very small number should raise an alarm in your own brain or in your own mind, right? That how come? It means people are not working on it. Is this possible that PP is such a hot topic, vaccination is such a hot topic, and the people around the world, there are thousands and thousands of universities and researchers and published literature. How come? So it means there is some fault in searching your literature, right? So today we will talk more about having how to search literature, right? So after having identification, first you have to justify it. Number of additional records identified through other sources, screening number of records after duplicates are being removed. And after duplicates, how much have been left, Meha? 86. Do you think it is a good number, vaccination, 86? Even you have more than 80 vaccines that are in clinical phase 3 trials. And don't you think that a lot of work has been published before they have come to the clinical trials 3? उनका एनिमल ट्रायल कहीं पब्लिश हुआ होगा कि पब्लिश होने के करीब होगा, राइट? तो इवन जितनी वैक्सीन हमें अवेलेबल है, आपको तो नंबर ऑफ आर्टिकल्स भी उससे कम जा रहे हैं. अभी तो बहुत लोगों ने क्रिटिसाइज किया होगा वैक्सीन के डिफरेंट रेजीम्स को, डिफरेंट प्रोसीजर्स को, साइड इफेक्ट्स रिपोर्ट किए होंगे. देयर आर सो मेनी अदर एस्पेक्ट्स दैट हैज बीन कवर्ड टू. So after removing the duplicates, if you come up with a very small number like less than 100, again, there is something that has to be looked again and again and again, right? So number of the records screened, number of records excluded, eligibility, number of full text articles assessed for eligibility, number of full text articles excluded with reasons. Okay, how much were excluded and why? I would not make you to answer. I can answer it. If I am the researcher and I have only 80 or 86 articles, I would not exclude anyone because I don't have that quantity in my hand where I can properly exclude any article, right? So your inclusion exclusion criteria, everything has failed once the identification of the record, it is not proper. For example, in the end, if I only have 80 or 60 articles, what inclusion exclusion criteria is supposed to apply on it, right? So you have to be correct identification before coming to the eligibility, and included number of studies included in qualitative synthesis or quantitative synthesis. What is the difference between qualitative synthesis and quantitative synthesis? Please unmute your mic and let me know, Dr. Daud.
Qualitative synthesis is the systematic review, and the quantitative synthesis is the meta-analysis.
Right. In qualitative synthesis, we come up with the important findings.
Yeah.
And these things are important.
Malaysian.
So we have to come up with what are the factors that are causing hesitancy. We have to write down all those factors along with percentages if reported. We don't have to recalculate it. But for quantitative synthesis, every sample size has to be added, again percentages has to be added, and we have to come up with our own analysis, right? So we have now come up with the praise by this mnemonic Casper. I hope you would be able to remember this. So the C stands for clear aims of research. Goal, why it is important, relevant. So whenever you are filling your Prisma guideline, first make your goal or make the relevance, right? For example, for if you are talking about personal protective equipment, you should be very clear that my aim is to find out about personal protective equipment that has been used now for more than 1 year. If you are doing work on hesitation for vaccination of COVID-19, you should have a clear aim in your mind. that people here in Pakistan, they are reluctant to get the vaccination. And I want to know what global trend is being followed, what other countries are doing with the hesitation in vaccination, right? This can be one aspect. Then you have to come up with A. A stands for appropriate methodology, right? Methodology should be very strong. Whenever you are scanning through any document or the full text, I have told you that you have to remove all those who are incomplete or who are just in the form of abstracts. You have to go through the full text articles. So the appropriate methodology has to be designed, and then the sampling strategy. S stands for sampling strategy. From the samples, you have to be very clear about the participants, right? And the participants, all the ethics would be applied to the participants. And what are those ethical principles? Autonomy, justice, non-maleficence, beneficence, veracity, and confidentiality. There are 6 principles, right? And 2A and 2B are beneficence and non-maleficence. So there are 6 principles. And all those 6 principles should be adhered with, right? So after ethical issues, we come up with, again, for the participants, we have to come with data collection analysis, then findings and conclusions, and what would this research would add to the existing literature, right? Just yesterday, someone was telling me about a systematic review where the validation of a PCR test has to be done with other tests. So what was my question was what that would add to the research, right? What value would be added to the existing knowledge of the research? You have to do it in the lab. Yes, it would add value to the research. But if you just want to do systematic reviews, it would not add the value to the existing research. We all know that PCR is the gold standard. And what other tests that are available, they are much lower in sensitivity and specificity. And even the PCR, we know for COVID-19, it is only giving 65% sensitivity for both nasopharyngeal swab, both